give us surgical tips and tricks in the management of myopic Foveoschisis. Let us all welcome Dr. Vishal Agarwal.
Thank you, APA, AIOS, and especially Dr. Ritesh for having me here. I'll be, talking about management of pathological myopia macular hole with RD. Just a brief, we know that pathological myopia, that is a globe elongation of at least, adaptive power of more than -6 diopters. It has a high disease burden, and myopic Foveoschisis occurs in around 30 to 40% of patients having more than 8 diopters of myopia. And the resulting sequelae is excessive axial elongation, mechanical stretching, posterior staphyloма. In the final stages, of course, there is myopic tractional Foveoschisis and myopic macular hole with posterior pole fluid. So I'll be discussing the surgical part, and these are the problems normally encountered with these difficult cases, because the length is a problem, the visualization is a problem because there is poor contrast, and PVD induction is a challenge in these eyes as compared to routine RDs, and a normal common algorithm for the management to give you the best results in most of these cases. So first, the visualization. So even if there is a small lenticular opacity in a myope and the patient is more than 40, I will go with a combined procedure, that is a phaco-vitrectomy, because you can get away with routine RDs in a small amount of lenticular opacity, but even a small amount of cataract will give you a lot of spherical aberrations in high myopic eyes. So you can see we have done a phaco and we have done the vitrectomy, and you can see the crisp contrast of the ILM. Otherwise, you might miss that, and you might remove the ILM in piecemeal because the contrast is so poor. So always either make the patient pseudophakic or do a combined procedure in these cases. Of course, the length is a big problem because we don't have instruments commonly available. So I prefer peeling in these cases with a contact system, because if you are going with a non-contact visualization system, actually your forceps, which is peeling the macula, is virtually perpendicular, and the rim of the non-contact system will touch the shaft of the forceps. So it's a good idea to use a contact lens. It gives you excellent magnification, it gives you excellent resolution, and the touching of the forceps with the shaft of the non-contact system is avoided. Uh, of course, you can, I can do the peeling from both the hands. So in this case, my right hand was not reaching the macula, so this is the peeling from the left hand. And you can try these maneuvers apart from the routine things, like creating a posterior, more posterior ports, or removing the trocar to reach the posterior pole. The third point is PVD induction. So there is a lot of, actually universal presence of vitreoschissis in these cases. So routine, cutter aspiration will not work. If you think that PVD is complete, you're wrong, and you have to restain it, and there'll always be a thin layer of, vitreoschissis present. So this is the technique we employ. So if the length is around 28, 29, this technique works fine. You inject some PFCL after staining. You make a small cleavage plane on the hyaloid, and you just, widen that hole in the hyaloid, and just with the blunt dissection with the light pipe, you just enlarge that cleavage plane, and the whole PFCL bubble actually goes inside the subhyaloid space. It's a very atraumatic and a reproducible technique. And then finally, you fill more PFCL in that well, and that cleaves the hyaloid till the mid-periphery, and that works fine in most of these cases. But that technique cannot be applied in patients having axial length more than 30 mm, because if you inject PFCL in these cases, actually you're increasing the axial length. So these severe eyes, you have to be patient, you have to grasp and re-grasp with the cutters and the forceps. You can see the length here. I'm barely able to touch the tip of the hyaloid. So you have to be patient, and it comes off eventually, but it is not a fast procedure. So no PFCL in more than 30 mm axial length eyes. Of course, you can use PFCL in less longer eyes. But in spite of all this, we know that these are complicated cases, and there are suboptimal, results in these patients. And this is one of the cases operated somewhere else. And just because of incomplete hyaloid removal and incomplete dissection, there was a recurrent hole, late reopening of the hole, and a re-RD. And we stained that with the trypan blue, and we did the resurgery. Of course, we did achieve a good anatomical outcome, but the visual outcome was suboptimal. So I'll tell you what we do in two types of cases and what is our algorithm of managing these cases. So first is, in with the contrast is actually manageable. So you can see the ILM. So we make posterior ports, we induce the PVD by restaining with the triamcinolone acetonide. We make sure that there is no Foveoschisis left. And this is a myopic macular hole with posterior pole fluid. We stain the posterior pole with brilliant blue, and here you have to keep that brilliant blue for some more time than the routine RDs, otherwise there will be poor staining. We inject a small bubble of PFCl at the posterior pole. We can see the blue staining. The contrast is not as bad as we have seen in the previous cases, and we now start peeling in an inverted fashion. And the beauty of this technique is that you don't need an extra retinotomy to drain the posterior pole fluid. It resolves itself if you have sufficient ILM. The second trick is that you have to peel it in a wider fashion, much wider than the routine macular holes. So the area of the peeling actually should correspond to the edge of the staphyloma, the curvature of the staphyloma. So if you don't do that, the retina will not be pliable enough and it will not relax it enough to close that hole. So a small peeling will cause a late reopening of these holes. So the area of the peel should be wide enough, encroaching the curvature of the staphyloma. Now once this blue dot is in place under the PFCl, you can see sufficient flaps have been made. I'm not stuffing it practically, but just just keeping it over there. And the PFCl makes it wet. It does not displace after aspiration of the PFCl. Now I'm aspirating. I have not made a second retinotomy here. So I'm just aspirating. The flap stays in place. And you can see the fluid has shifted peripheral because of the PFCl. But even on the second day, that fluid disappears. You have to make sure there is no additional break, and the results are excellent. So these are when the contrast is okay. But if the contrast is bad enough, actually injecting PFCl, we won't even find the hole, let alone the the staining of the ILM. So here I injected the PFCl, I aspirated it again, and under fluid you can see such a beautiful contrast. So just to exemplify that, this is a representative case. So this is a ICL RD, post ICL RD, pathological myopia, more than 30 mm of axial length. So in the previous case, we injected PFCl and did the peeling under PFCl. So we have made posterior ports. There is a macular hole in the center. There is no other hole which has caused this RD. We do the routine maneuvers. We induce the PVD. We do multiple stainings and make sure that there is no vitreous left behind at the posterior pole. Otherwise, it will not stain. Then we inject brilliant blue. And now we have not injected PFCl because the contrast is very poor. Now, if you inject, if you start peeling under a detached retina, the first pinch and peel will be a little tricky, but once you get the flap, it is actually very simple, and the whole, you can make multiple flaps like I am making, and you can direct them towards the hole to make it an inverted flap technique. Only the first pinch is a little tricky. Now I have all those flaps in the center. Now is the time when I do the base dissection and all the maneuvers. And in the last, I inject the PFCl to keep that flap in place. So if I had injected that PFO bubble before that, I would not have seen the ILM. I would have not seen the hole. So that is the difference between axial length of around 28 and axial length of more than 30 mm. And these are the results of the cases I've shown you, and they are fine after gas injection and resolution of the gas bubble. So to conclude, myopic foveoschisis with macular hole is a complex surgery with varied intraoperative surprises. Of course, we do all our thorough preoperative workup and planning, but the crux of success is combined procedure, phaco-vitrectomy whenever needed, a thorough PVD induction, multiple stainings, longer stainings, posterior ports around 4.5 will also suffice in axial length more than 30 mm, and of course, a clear communication about the chances of failure, late reopening, and modest improvement should be done to the patient and their attendants. Thank you so much.
Thank you.